So as we know, WHO is developing a global strategy towards eliminating cervical cancer as a public health problem, which includes 2030 triple intervention coverage targets for scale-up of HPV vaccination to 90%, and twice lifetime cervical screening to 70%, and the treatment of pre-invasive lesions and invasive cancer to 90%. But if we achieve this goal, this 90, 70, and 90 target, what is going to be for all of our women, and can we reduce the mortality related to cervical cancer? In 2020, the WHO Cervical Cancer Elimination Modeling Consortium published their model, their estimation on whether these strategies can reduce the rates of cervical cancer mortality in low-income and lower middle-income countries. Their work is done in 3 core scenarios. There are 3 ones. First is girl only vaccinated at age years with catch-up for girls aged 10 to 14. This is a vaccination only project. And the other one is, besides the vaccination, they will have a once lifetime screening and cancer treatment. And then the third core scenarios was the girls only, besides the vaccination, there will be twice lifetime screening and the cancer treatment scale up, which is the WHO's 1970 and 19 that targets. So let's say what's gonna happen if we have that. In 2020, they estimate cervical cancer mortality rate across all those 78 low and middle income countries was estimated as 13.2 per 100,000 women. But by 2030, which is the time when the 1970-19 triple intervention target achieved, the first one, the S1 scenario, which is the vaccination only, would only have minimal impact on cervical cancer mortality with a 0.1% reduction. But if we look at if those girls got vaccination and also had at least one time screening, the mortality were reduced by 34%. And 40 years later, the S1, the vaccination only strategy will reduce over 60% mortality. But when we look at the WHO 1917-19 strategy, it will reduce over 90% of the mortality. And 100 years later from now, the vaccination only will show its significance. The mortality of cervical cancer will have nearly 90% reduction. And also actually the WHO, the 1917-19 in reduction deaths at age 30 to 69 years old would be 34% in 10 years, and also over 95% in 50 years, and nearly 100% reduction in 100 years. So what does this mean? Which means that screening and treatment still remain crucial for protecting women in 100 years. So I'm going to gave a very brief introduce about the current screening and management and treatment of women with HPV infection. This is a report from Denmark based on its nationwide registered based data. So they look at the follow-up of the women with non-negative HPV screening test between March 2012 to 2016. For those who had positive or HPV test or inadequate HPV test, the adherence to recommendations during the first 3 follow-up visits is not that good. For most of our women at their reproductive age, they have over 61,000 of them. Only 43 of those who had a positive HPV test follow the recommendations during the first 3 follow-up visits. And when we look at those who are older, there's only 26 of them who are follow-up, who had the recommended follow-up. It's quite, remember, this is in Denmark, in Europe. And then when we go to Argentina, they had a project for women aged 30, over 30 or older, and followed them for about 5 to 6 years, about 5 years. There were total nearly 50,000 patients. Okay, when we look at those over nearly 7,000 patients, 7,000 women had a positive HPV test. Only 26% completed the second test within the time frame. Look at this figure on the right of the PPT. The dark shaded bar is the time frame for recommended follow-up. You will see that actually very few of them, less than 30%, completed the recommended follow-up. As of March 2018, which should be 5 years later, the follow-up, the second retest of HPV just increased to 70%. Actually, there are many efforts to increase the recommended follow-up after a non-negative HPV test. The clinicians in Honduras conducted a cluster randomization study. And they found that among all HPV positive women, only less than 4% returned. And after the healthcare provider to recall and the proportion of those who returned to the follow-up increased to 71%. Just use a phone call and other reminders, contacts, like send a message or get into the in-person visit. So which means, yes, the retest or the recommended follow-up is quite low, but if the healthcare system can do something, a significant increase of those who got HPV test positive will go back to the clinic to have their retest or to have their follow-up for either treatment or retest. And in Denmark, they had a central, they had done a 1-to-1 cluster randomized controlled trial, and 2 test the hypothesis that if we convey the cervical cytology result directly to the investigated women, whether this strategy will improve timely follow-up compared to the conveying the result via the usual way, which means the message is sent to their general practitioner first, and the practitioner will send this message to the women. They have this is a very large a cluster randomization controlled trial, and the result showed very good. The efficacy is very good. And by the third month after the positive result coming out, the intervention group had a 50% without timely follow-up rate compared to the 19.5% in the usual group. And the difference is significant. So seems if we gave this patient, these women, some intensive contact or strategy, we can change something. We can change the current very low proportion and a very low rate of recommended follow-up. But what's in China? What happened in China? Actually, everybody knows that in China, we have 2 cancer screening programs supported by the government, which include breast cancer and cervical cancer. And by 2018, the cervical cancer screening rate already reached to 15 to averagely, it's 15 to 25%. But data for follow-up after a positive screening result is limited. I even cannot find any. So based on all those information we had back to 2021, we started a cohort study. We proposed a cohort to provide the adherence to recommended follow-up after the positive HPV test. The aim of this cohort study is first to describe the status of follow-up and to investigate what kind of factors to impact the decision-making for HPV infections, such as the follow-up and treatment, and also to identify potential factors which may influence the treatment decisions. Our ultimate goal is to provide the real-world evidence to support optimal decision-making in the management of HPV infection, and ultimately strive to achieve the goal of 90% of women with pre-cancer treated. This study was conducted in a very low income county. You will say from the map of China, this county is just set in the middle of our country. This picture shows this very beautiful place, but there are mountains all over the county. It's really hard to find a very flat place to get people together, to gather people. And this county is kind of back to 1990s. It had the second highest cervical cancer prevalence. And there were only in total 30,000 women aged 18 to 65 years in the whole county. Then we designed using a mixed method and a 5-year prospective longitudinal cohort study. For the cohort, women diagnosed as HPV infection during the nationwide screening program will be the participants, will be recruited. This shows the recruitment procedure, and those shows the follow-up procedure. The main outcomes of this study would be three outcomes. First, the compliance with guidelines. If you got a positive result, what should we do? And when the women coming back, what kind of treatment or management strategy will they choose? And also how the HPV infection status changed over the follow-up or over some treatment. So this table 1 showed the data collection schedule. It will be, we will have totally 8 visits. The first 3 visits will be complete during the first month of the screening. And after that, those women will be followed every 6 months. So to conduct this project, we used our own data management platform, which is a project-based data collection and storage platform. It accommodates the multi-projects, and all projects protected by account and private account and password. The data access levels is controlled by researcher themselves, not by the engineer. And also we can define our own CRFs, and they have the ability to collect data longitudinally. And the clinician and the researcher can control data exports for analysis anytime if the PI wants the data. Then we have a WeChat mini program to connect the data electronically, which enable the high frequent patient data collection. For example, we can do the symptoms and the functioning data collection every day when patients are back to home. And this, based on this platform, the State Key Lab of Ultrasound in Medicine and Engineering is establishing the data network over the country. Right now, we already have 75 hospitals and over 30 million data on this board. And we use blockchain technology to provide a transparent, secure, and efficient way to manage data. Okay, this is the baseline investigation. We investigate all women in that county aged 18 to 65 years old, which right now it is a little bit over 21,000. We use questionnaires to get the information about their general health status, which also include their history of gynecologic conditions, include cervical diseases. You will see we use PAD, here is a PAD, or paper-based questionnaires, and via face-to-face interview. Right now, in our cohort, we have total screening women up to just a little bit over 5,500. And currently the HPV infection rate is about 17%. It's quite a lot higher than that in the Eastern China. But I would say it may be because of the age groups, because in that county, all the young people, the young ladies already got out of that countryside. They went to the big cities, and we cannot find that much young ladies in our screening program. And the follow-up is not that good. The 6 months follow-up is about 50%, and 1 year down to 20%. To the non-adherence reason, there are several ones. Lack of money, the transportation is difficult because all of those villages are spread in the mountains, and also they have to do child care or any other housewife's job. Also, they are hesitant on the effectiveness of treatment. For example, when the women with HPV positive test came back 6 months later, they found that their HPV is still there. So they feel kind of disappointed. So they won't come back next time. And also we found that for the girls under 14 in elementary school and middle school, the HPV vaccination rate is quite low, especially for those in elementary school. We interview the girls themselves and also their parents, and also the school teachers and the government officers, identify several barriers for vaccination. First of all of those, even the teachers, their parents thought those girls are too young to be vaccinated. Using this data, using the baseline data, we have conducted 2 cross-sectional studies. First is the HPV infection in older women. The purpose is to explore the epidemiology and factors influence the HPV infections. We use the cross-sectional design and the data extracted from baseline investigation of these cohorts. So those are the inclusion and exclusion criteria. We have published this paper, these results just 1 month before. And we included 2008 patients from 40 to 65, and 21% had a positive HPV test. And the prevalence of HPV infections increased by age group. You will say, please say the left one. The green line shows the high risk HPV infection. You will see that it increased by the age. And also the genotype of HPV in age groups are quite interesting. For those 40 to 59 years old, the top 3 was 52, 53, and 16. But for those older ones, the first one, the top 1 is 58, and then 52, 53, 16 is not there. And also, we identified that factors related to HPV infections, age at first marriage, younger than 18, and also if they have 2 or more number of pregnancy, and also the education level. They're all risk factors related to HPV infection, which suggests us some health education program should be focused on this group of women. And also we look at how those women, how the knowledge and the practices regarding HPV and cervical cancer screening. We also use those patients, and we have measured their HPV-related knowledge by 7 questions. And also we measure their attitude for willingness to receive the HPV vaccine. And also we define a regular screening as they have at least 1 screening for cervical cancer in the past 3 years. The preliminary result showed that for those who had, very few had a regular screening for those women. Over 80% would only have one time. And their knowledge of HPV is significantly lower than those who have regular screening. And also for the reasons for irregular screening, mostly is, I don't know. I should check regularly. And I don't know what can this screening benefit me. And I don't have any symptom, I'm good. I don't have to. No time, traffic inconvenience, and fear of the procedure, all kinds of things. And also we had an attitude toward the HPV vaccine, which is surprising us. Actually, although there is a significant difference, everybody thought if I had a daughter, I would give them, let her receive the HPV vaccination. It's quite, yeah, it's a little bit surprising. Okay, those are our preliminary results. For future plans, we will have a very intensive follow-up cohort to enhance the follow-up, to recall those women back regularly and back as recommended. And we set up a small cohort in a village about 60 kilometers to the downtown. And we are introducing the new treatment technology, the HIFU, the focused ultrasound, in the HPV-related cervical lesions. This will be done. This is undergoing in our cohort. So in all, what I'm thinking, what I have done, we have done here, is that to show that the necessity to have a more specific and more professional management plan or strategies to those women who got a positive result of their screening test, but after that, nobody cared them, I would say. Even the doctors, the clinicians called them and say, oh, okay, you got a positive result and you should come back. And then nothing happened. There's no strategies, no plans, no healthcare insurance to take care of this. So I hope if anyone in the audience tonight can join us, we will have a big program in China, and we want to establish the mode to manage those women before they get into the doctor's clinic to treat their already invasive cancers. Okay, that's all. Thank you for your consideration.